I would like to conclude and thank you very much for your attention. Thank you.
After having this interesting introduction about the role of precision medicine in the triple-negative breast cancer, actually the upcoming two lectures are very important, and that's meaning for the clinical outcomes of the patient. We'll start with Professor Marwan Ghosn, who is on the live with us, who will discuss about what is the best approach for TNBC patients after achieving a pathological complete response.
Thank you, thank you, thank you, Mr. Chairman, for your introduction, and thank you for the organizing on insisting on doing this very interesting conference despite the COVID situation in all our countries. First of all, also, I would like to salute my friend Dr. Hisham Al-Ghazali for all his efforts in making this happen. I do not have any conflict of interest or disclosure related to this presentation. Everybody knows that triple-negative breast cancer is a very distinct entity in breast cancer. And indeed, it is a very difficult entity. In our countries, the percentage of the patients with triple-negative breast cancer is around 10 to 15%. This particular triple-negative breast cancer is responsible for excess mortality in our patients. Nevertheless, we need to know that there is an heterogeneity of triple-negative breast cancer that we know today. And even there are multiple subsets with varying targets like basal-like 1, basal-like 2. Androgen receptor signaling also has been identified and present in this subcategory. And we know that genomic instability is common in triple-negative breast cancer. The last slide in my introduction will try to see that there are multiple risk of relapses over time with triple-negative breast cancer. The most important and the most highest relapse rate is usually seen within the first 2 years, but the relapse rate will continue up to 6, 7, or even sometimes 10 years. And there is a main difference in the recurrences between triple-negative breast cancer and the other breast cancer, meaning that in triple-negative breast cancer, you usually have organ involvement like lung, like brain, and like disseminated bone. So these triple-negative breast cancer will have a preferential metastatic spreading to lungs, liver, brain, bone, also less common when compared to luminary cancer. So, what to do after giving a neoadjuvant chemotherapy for a triple-negative breast cancer and that the patient achieved pathologic complete response? You know, this is the ideal situation for our patients, but still it is not enough because a substantial number of these patients will continue to relapse. We have 3 options discussed in the literature until today. We have the story of the bevacizumab, we have the story of the capecitabine, and we have the recent stories of immunotherapy. Let us begin with the story of capecitabine. This is one of the first studies. All these studies for capecitabine were published last year. So this is the study by GCAM and Siboma. Here you have triple-negative breast cancer, classical one. They received prior standard neoadjuvant therapy with anthracycline plus or minus taxanes, nicely operated, received or not received the radiation therapy according to the standards. And after having the complete response, pathologic complete response at the control of the primary tumor, patients were randomized either to capecitabine for 8 cycles, so this is nearly 6 months of treatment versus observation. If you look to the whole population, there were no statistically significant increase in the disease-free survival nor in the overall survival. But if we look into the non-basal phenotype of the patients, you have a statistically significant increase in the disease-free survival with capecitabine in the non-basal phenotype. And if you look into the overall survival, also in the non-basal phenotype, you have a better overall survival. The second trial is the one published earlier in September 2029. This was by our colleagues in Japan, adjuvant addition of capecitabine to early stage triple negative breast cancer receiving standard chemotherapy. So in this meta-analysis, also they saw that the adjuvant addition of capecitabine to these patients shows significant disease-free survival and overall survival. And last, the most important trial is this one, also recently published in the JAMA, and this is the effect of capecitabine maintenance therapy using a lower dose and a higher frequency and for a longer period of time. And in this patient, you see here the trial design. Capecitabine maintenance was given at a 650 milligram per square meter twice per day, continuously over 1 day and over 1 year, and this was randomized to observation. Primary endpoint was reach disease-free survival. The 5-year improvement in disease-free survival was 83% versus 73%, with a hazard ratio of 0.63, although there were no significant improvement in overall survival. And if you look into all the subcategories of the patients, lymph node positive, lymph node negative, high Ki-67, low Ki-67, wherever the regimen and the age of the patients, the arm of capecitabine was better than the other arm. And the most common related adverse effect was the classical hand and foot syndrome, with only 7% of the patients experiencing a grade 3 event. So the conclusion of this trial was supporting the use of long-term of oral capecitabine with lower dose. What about of the earlier study of bevacizumab? You know that before you have this Beatrice study design, it is not, you know, tackling directly what we are looking for, but it can give you an idea. These patients were randomized when they have triple negative, resected patients, either to standard chemotherapy or to standard chemotherapy plus bevacizumab, followed by bevacizumab as a maintenance. There were no differences between the groups, either for disease-free survival nor for overall survival. And the other trial of ECOG E5103 also, where this was a phase 3 randomized study of adjuvant AC followed by paclitaxel with or without bevacizumab. Also, as you see, there were no differences between the disease-free survival and the overall survival. So it looked like adding bevacizumab to this trial wouldn't add anything, especially on those patients who have a pathologic complete response. The last part of my presentation is to give a little bit hint of what will be the role of immunotherapy. We have at least 2 studies, one with pembrolizumab and the second with atezolizumab. The design of the study is not tackling to the what to do on the pathologic complete response, but you know, it gives us also hints in this. In the keynote 522, pembrolizumab was added to the chemotherapy in the neoadjuvant setting versus placebo. Surgery was performed, and to all patients, the patients who received pembrolizumab before as a neoadjuvant, they will continue pembrolizumab and a maintenance treatment for 6 months, and the patients who received placebo in the neoadjuvant will continue, you know, placebo on adjuvant. And the primary endpoint was the achievement of pathologic complete response. Secondary endpoints, the pathologic complete response, you know, and the adverse effects and the event-free survival, overall survival. And, you know, there were exploratory endpoints by the subgroup of patients. So as we see, the primary objective of this study was achieved. The pathological complete response for the patients who received pembro was significantly better than the pathological complete response than the patients who did not receive pembro, and the patients who were PD-L1 positive were better than the PD-L1 negative, but these results, the pathological complete response was achieved better with the immunotherapy with pembro regardless of the PD-L1 status. And if you look, at the event-free survival, you will see that the hazard ratio was better, with the patients who received pembro. And you have exactly the same design and the same result when you go to the Impassion 031, which is the addition of atezolizumab to neoadjuvant chemotherapy in stage 2, 3, and triple-negative breast cancer, where atezolizumab was added to doxorubicin, cyclophosphamide, and nab-paclitaxel in the neoadjuvant, then continued to nearly 8 months as a maintenance treatment versus placebo or observation. And also here you see that pathological complete response was statistically significantly better with the patient who received atezolizumab, and this was also regardless of the PD-L1 status of the patients. So as in conclusion, what are my take-home messages? Triple-negative breast cancer, only accounts for 15% of all breast cancer, but is responsible for an excess of mortality. There are high risk of relapses characterized by a preferential metastatic spread to visceral organs with those patients who are triple-negative breast cancer. The only studies who are showing any beneficial effect currently are by adding capecitabine as a maintenance therapy, for the patients achieving pathological complete response. We have very interesting studies and result with the neoadjuvant adjuvant use of immunotherapy in this category of the patients, and the use of bevacizumab is not supported currently with the results of the study. Maybe a combination of immunotherapy and immunotherapy as a neoadjuvant and adjuvant maintenance and capecitabine would be eventually the way to go in the future. We are still awaiting for more data to come. And with that, I would like to thank you very much and so much for your kind attention.
Thank you, Professor Marwan Ghosn, for this elegant presentation as usual, and thank you for being with us virtually.
Thank you very much.
Yeah, you are welcome, sir. So to complete the picture, I have the honor and the pleasure to ask my professor, Professor Ala Andil, to come to give us the other part of the picture. Those patients who didn't achieve the pathological complete response, what shall we do for them? Professor Ala is a well-known figure and professor of clinical oncology, Alexandria University. The floor is all yours.
Morning, everybody. First, I'd like to thank the organizers for giving me the opportunity, and I'd like to welcome everybody. Marwan, كيفك؟ إن شاء الله دايما بخير. So